Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello and greetings to everyone from Hyderabad, India. I am Dr. Nihaal Reddy, and I would like to thank the organizers of SPIN for giving me this opportunity. It is truly a great honor to present in this great event. I will be talking about unusual pediatric strokes. I have no disclosures or conflicts of interest. I would like to acknowledge and thank my mentors and colleagues for sharing their invaluable knowledge and cases for this presentation. We'll have a brief overview of 3 cases which presented with stroke-like symptoms. None of these patients had any abnormalities on diffusion-weighted imaging in the acute and early subacute stage. There was no significant abnormality on angiography. We'll have a look at these 3 cases among others and see how the clinical presentation and other sequences and imaging modalities help in diagnosing these atypical and uncommon cases. Unlike the adult population, the pediatric age population presents with rather non-specific symptoms for stroke. Mackay et al. In a cohort of 382 patients tried to differentiate the clinical features for a patient with stroke and their mimickers. Focal weakness, speech disturbance, weakness of the face, arm, and legs, dysarthria, and inability to walk were specific features for stroke. The child was also well a week prior to the onset of symptoms in presentation of stroke. The age of presentation is also important. It is rather non-specific in the early childhood, whereas as the child grows towards a more adult age group, it presents with more specific symptoms for stroke. The uncommon strokes can present with multiple risk factors and etiologies, which can be categorized into arteriopathies, cardiac abnormalities, hematological and prothrombotic abnormalities, abnormalities related to mechanical causes, and drug-related issues. Going back to our first case, it was an 11-year-old girl with subacute left-sided weakness, more in the upper limbs, associated with aphasia. There was no infarct or stroke-like lesions demonstrated on diffusion, whereas on the SWA images, we can appreciate that there is prominence of the cerebral vasculature on the left cerebral hemisphere. There's also mild paucity of the terminal segments of the left MCA, and on perfusion study, there is hypoperfusion in the left cerebral hemisphere. These changes constitute a transient focal neurological deficit corresponding to hypoperfusion. SWA images demonstrate these prominence of the cortical vessels on the abnormal side. There is paucity of the arteries on the abnormal affected areas, and there is decreased perfusion in patients scanned less than 14 hours from symptom onset, whereas there's normal perfusion or increased perfusion in patients scanned more than 17 hours from symptom onset. Going on to our next case, this child presented to us with recurrent stroke-like episodes and was scanned multiple times. The first presentation, there was right hemiparesis, difficulty in walking, cerebellar signs, and slurring of speech. On the diffusion-weighted images, we could not find any abnormalities in the brain. There was a HERE1 deformity with foramen of magnum stenosis. No abnormalities of the intracranial arteries on MR angiography. Patient had another episode of hemiparesis and was later on surgically intervened for a posterior fossa decompression. Post-op day 6, the patient again had right hemiparesis and was again scanned. And the scan again, we do not see any abnormalities in the brain parenchyma. There is still some persisting stenosis at the level of the foramen of magnum and craniovertebral junction. No abnormalities were noted in the MRA involving the brain and the neck vessels. These symptoms persisted for 24 hours and the patient was then discharged. 1 month later, the patient presented with dense left hemiparesis with bulbar dysfunction. Suspecting a mechanical cause, provocative angiography was done with the child's head rotated to the left and right. And at this moment, there is an absence of flow in the distal vertebral arteries when the head is turned to either the right and the left. Volume tenders can again demonstrate focal areas of stenosis in the distal segments of the vertebral arteries when the child's head is turned towards the right and the left. The child was operated and a C1 and C2 fusion was done. This is video of the child 1 month later in a cervical collar. She has since not presented with any other stroke-like episodes or complications. This is known as Bow-Hunter syndrome or rotational vertebral artery syndrome. When the head is in neutral position, there is no compromise of the vertebral arteries. But when the head is turned to either the right or the left, there is stretching of the vertebral artery, which causes dynamic compromise and can present with transient ischemic changes or stroke-like episodes in the brain. Bow-Hunter syndrome causes vertebral basilar insufficiency due to dynamic mechanical impingement. In pediatric age group, it is usually associated with cervical bony abnormalities or ligamentous laxity. Repeated damage to the vertebral arteries during head turning causes intimal and endothelial injury of the arterial wall, which later forms a dissection and platelet aggregation and emboli formation, resulting in stroke. Literature review demonstrated 26 cases diagnosed with Bow-Hunter syndrome. Majority were male. Dissection was demonstrated in 18 of the 26 cases. Stroke was evident in 23 out of 26 cases, and the majority had surgical intervention in the form of fusion or decompression. Moving on to our next case, which is a 14-year-old girl with acute pain while taking a shower. She was shampooing her hair with feeling of tingling and diminished power. The patient was able to walk. MRI in the acute setting did not demonstrate any abnormality. There was still a clinical suspicion of a possible cervical injury or a cervical cord injury. X-ray of spine was done to look for any fractures, which was normal. MRI of spine was done, and on the T2 images and diffusion images, you can appreciate that there is hyperintensity of the anterior segment of the spinal cord involving the lower cervical and upper thoracic regions, with corresponding areas of restricted diffusion in the region of the anterior spinal cord. These changes are suggestive of spinal cord infarction. It is defined as a spinal cord death attributable to ischemia based on pathological imaging or other objective evidence of focal ischemic injury in a defined vascular distribution. Arterial infarcts are more common than venous infarcts. Arterial infarcts present in a more acute fashion, whereas the subacute presentation is common in the venous infarcts. Anterior spinal artery infarction is most common. The presentation is usually abrupt and painful, as the radicular arteries also supply the ipsilateral hemivertebrae, meninges, and paraspinal musculature. In the acute and early subacute stage, there can be abnormalities on the T2 varied images and restricted diffusion along a defined vascular territory. They can be associated with vertebral body infarcts. In the late subacute stage, there's cord edema and expansion, whereas in the chronic stage, they present with non-specific myelopathy and can be associated with Velitan degeneration and paraspinal muscle atrophy. Literature review a few years back demonstrated that the major cause for pediatric spinal cord infarction was minor trauma, followed by iatrogenic causes. Spinal cord infarction presents with specific features pertaining to specific arterial territories. The involvement of the bilateral anterior spinal artery territories demonstrates motor deficits on both sides with spinothalamic sensory deficits. Unilateral involvement of the anterior spinal artery territory demonstrates hemiparesis with contralateral spinothalamic sensory deficit. It is usually due to infarction along the sulcal artery territory. Posterior spinal artery infarcts present with unilateral motor deficits and lemniscal sensory deficits. The anterior and posterior spinal arteries constitute the radiculomedullary artery diseases, whereas if the significant area of the cross section of the spine is involved, the patient presents with bilateral motor deficits and complete sensory deficit. And a central cord infarction, the patient presents with bilateral spinothalamic deficits, and usually there is no motor deficit. The latter two are due to global hyperperfusion caused by watershed territory infarcts or infarcts along multiple artery abnormalities. An emerging etiology in pediatric age group is fibrocartilaginous embolism. In a degenerative disc, there is a retrograde flow of the nucleus pulposus into the spinal vasculature, which causes the infarct of the spinal cord. Here are two cases with posterior annular tear and degenerative disc with loss of normal T2 signal intensities. Both of them have corresponding areas of spinal cord infarction, predominantly in the anterior spinal cord artery territory. Moving on to our next case and presentation is a 15-month-old child with stroke and transient hemidystonia following a trivial fall from bed. And this is a scan 3 months after the symptom onset. You can appreciate that there is bilateral basal ganglia, chronic ischemic changes with gliosis and encephalomalacia. On the SWI images, you can appreciate that there is focal areas of blooming in the bilateral basal ganglia, the left more than right. This is likely suggestive of mineralization, and these changes constitute findings of mineralizing angiopathy of the basal ganglia. It is a common disorder in the Indian subcontinent, whereas it is less reported or less common in the Western population. The basal ganglia are predominantly supplied by the lenticulosteroid arteries, and the proposed theories for these are: in the infants, the lenticulosteroid arteries are usually have a more acute angle orientation. The incompletely developed skull-based bones result in the brain parenchyma being relatively mobile and prone to injury. The unmyelinated brain may be more susceptible to a greater degree of mechanical distortion with minor head trauma. Mineralization increases the vulnerability of the vessels to stretch during head trauma, and the stretching in turn causes vasospasm and thrombosis, which in turn causes ischemic stroke. CT is the modality of choice for diagnosing this condition. 3 major studies were carried out in the Indian population by Lingappa et al. With 23 patients, Gowda et al. With 38 patients, and Jain et al. With 48 patients. The common findings in these 3 papers were: the child was previously healthy and the age of presentation was from 6 months to 36 months. There was rapid onset of neurological deficits, usually hemiparesis, with transient hemidystonia. Very few cases had a positive family history. All investigations for cause of childhood stroke and procoagulant study states were non-contributory. There was no evidence of long-standing infection. MRA was not helpful. CT was the modality of choice. And the treatment for these patients was aspirin along with physiotherapy and rehabilitation. Cilestazol was given for patients with recurrent strokes. We move on to metabolic disorders which present with stroke or stroke-like episodes. These are a few conditions which present with strokes. Here's a case given to me by Dr. Cesar Alves from Philadelphia. A 7-year-old male with 2 different stroke-like episodes within 2 months. In the first presentation, you can appreciate that there is cytotoxic edema in the left temporal and occipital region. No abnormality within the SWI images or the arteries. On the second presentation, there is subtle changes on the diffusion weighted sequences, but the perfusion study demonstrates hyperperfusion on the contralateral side with hyperperfusion in the right temporal and occipital region. There's no, again, significant abnormality on the SWA or MRA. And this patient presents with elevated and inverted lactate peaks. This condition is known as MELAS. It is primarily caused by mutations in mtDNA, commonly the MT-DLE1 mutation. They present with recurrent strokes, possibly due to deficiency of nitric oxide in the blood vessels of patients with MELAS, which lead to vasoconstriction and impairment of autoregulatory vascular mechanisms, resulting in recurrent stroke-like episodes. Imaging the gray matter is more commonly involved. The posterior lateral aspects are more commonly involved in the cerebral hemispheres. There can be skipping lesions in the recurrent stroke-like presentations. They usually do not conform to vascular territory. Lactate can be present on MRS in normal and abnormal areas. Basal ganglia calcifications can be seen in chronic stage, and there is no hyperperfusion on perfusion studies, in contrast to infarcts where there is hyperperfusion. Here's another inborn error of metabolism. It's a rare disorder which presents with alopecia, brittle, tangled, sparse hair. And on brain, we have bilateral subdural collections, bilateral basal ganglia lesions, a reduced brain volume, and tortuous abnormalities of the intracranial arteries. These constellation of findings are usually present in a condition known as Menkes disease due to mutation in the ATP7A gene, which is a copper transporter defect. We're moving on to our last spectrum of disorders, that is the genetic causes causing cerebrovascular disorders and pediatric stroke. Though there are many disorders listed here, the overall incidence of these genetic disorders is rare in a pediatric age group. In this case, where you can see there is bilateral white matter changes in the superficial cerebral hemispheres, possibly suggestive of chronic small vessel ischemic changes. There is a more recent focal infarction in the right frontal lobe. On angiography, we can appreciate there is a dilatation of the proximal internal carotid arteries with stenosis of the distal internal carotid arteries and a straightened appearance of the intracranial vasculature. The constellation of these findings can be seen in ACTA2 mutation. It causes multisystemic smooth muscle dysfunction syndrome and can clinically present with congenital mydriasis, ductus arteriosus, and pulmonary hypertension. The imaging, as described, has prominent features of dilatation of the internal carotid arteries, occlusion of the distal or the cavernous segment of the ICAs. Straight or broomstick-like appearance is characteristic. There is usually absence of moya collaterals, and small vessel ischemic changes can be seen in the brain parenchyma. Additional imaging features, as described by Darko et al. In the AGNR paper, is a typical V-shaped orientation of the anterior corpus callosum on the axial images, the squeezed appearance of the midbrain, multiple pontine indentations, and radially oriented frontal lobes due to deficiency of the anterior cingulate gyrus. The straightened appearance of the intracranial arteries was thought to be specific to ACTA2 mutations, but recent case reports suggest that they can be present in other disorders. This paper extensively evaluated for ACTA2 mutations with brain malformation and the straightened appearance of intracranial arteries, but it was negative for the gene. Another new gene, that is MYH11, also demonstrates the straightened appearance of the intracranial arteries with focal stenosis. So straightened appearance of the intracranial arteries itself is not pathognomic for ACTA2 mutations and can be seen in other disorders. Here's another genetic disorder in a fetal and a 4-year-old. The fetal scan, you can see there is right frontal lobe hemorrhage with podencephaly and possible cyanencephaly. And in the 4-year-old, you can see these white matter changes in the bilateral periventricular regions and the superficial cerebral hemispheres, suggestive of gliosis with prominence of the lateral ventricles. There's also thinning of the corpus callosum. These can be seen in COL4A1-2 mutations. They are the most common type for collagens and have multi-system involvement. The brain imaging phenotypes usually have small vessel ischemia, hemorrhage, porencephaly, scheidencephaly, hydranencephaly, and malformations. Other systems can be involved, such as cataracts and retinal artery tortuosities in the eyes, cyst anagenesis in the kidneys, elevated creatine kinase, and cardiac abnormalities. Here's an interesting case given to me by Dr. Astik Biswas from Sick Kids Toronto. On the FLAIR images, we have bilateral white matter changes in the superficial cerebral hemispheres. There is gliosis on the right parietal lobe, and on the angiography, you can see there is stenosis and tortuosity of the intracranial arteries with a moya pattern of presentation. On the X-ray spine, we can appreciate that there are butterfly vertebrae or segmentation anomalies. These can be seen in syndrome known as Alagille syndrome due to JAG1 mutation. It is a multi-system involvement with posterior embryotoxins in the eyes, cardiac abnormalities, renal abnormalities such as horseshoe kidney, myoma pattern in the cerebral vasculature, this characteristic facial dysmorphism of a lower triangular shaped face, bulbous nose, prominent chin, high forehead and hypertelorism, segmentation abnormalities of the vertebrae, and also there can be abnormalities of the bile duct. With a 12-year-old female with severe onset headache and dropping GCS, given to be by my mentor, Dr. Ajay Taranath from Australia. We have the FLAIR images where you can appreciate some sulcal hyperintensities and a focal white matter change. CT demonstrated cerebellar hemorrhage. CT angiography, there is focal irregularities along the bilateral middle cerebral arteries suggestive of a vasculitis pattern. And also on the renal angiography, there is focal stenosis or narrowing. These can present with abnormalities of the hand. And this was a case of Grain syndrome due to YY1AP1 mutation. They can present with stroke-like symptoms due to arterial occlusive diseases, hypertension, heart defects, hand abnormalities such as brachyssyndactyly, and fragility of the bones. This is my final case. It's an interesting case. It's a 12-month-old male with microcephaly, global developmental delay, and cerebral visual impairment with refractory focal clonic epilepsy, was born to consanguineous marriage, and mother noticed decreased fetal movements in the third trimester. The EEG demonstrated modified hypsarrhythmias. On the scalp, you can see there is changes of alopecia, hypertrichosis, and there's some abnormal texture of the hair. On the brain imaging, the brain itself is small. There are chronic changes in the bilateral cerebral hemisphere, predominantly involving the white matter and the cortex. There is ex-facto dilatation of the lateral ventricles. There's also some gliosis in the vermis on the right. Related to the small brain, there is a large cerebellum. And on MR angiography, there is hypoplasia of the middle cerebral arteries and anterior cerebral arteries, and also the right vertebral artery. Whole exome sequencing was done, and this patient turned out to be positive for LPAR6 mutation, stands for lysophosphatidic acid receptor 6. They are simple bioactive glycophospholipids widely found in the human body. There are a total of 6 receptors which function in cell proliferation, migration, and cytoskeletal changes. The LPAR6 is known to cause abnormalities of the hair and liver. Very few cases have been described, and the brain imaging findings are not yet clearly delineated. But the hair abnormalities have this typical texture of appearance of a wool, hence the name woolly hair syndrome. That should be my last case. I would thank you all for listening, and once again thank SPIN for giving me this opportunity to speak at this great platform. This image or picture is from the very first SPIN course in Adelaide. Great memories, great friendships formed, and hopefully we will sometime see you soon live in person. Thank you very much.